Okay. Well, there's a lot to go through. I'm hoping that we don't use the full 2 hours because I don't know if anybody's going to have an attention span that can last that long, but we'll see. So I think the first thing is rather than spend time introducing ourselves on the call or on the Zoom, just simply in the chat box, introduce yourself there, and then everyone will be able to see who's on the Zoom. I see Carolyn Villegas is there, Stuart Vincent, Tish Gilroy, Jennifer Norton, Kristen Phillips, hi there. I know I invited you at the last minute, but I'm glad you could make it. Tavora, hello. Selena. Ashta, if I'm pronouncing that correctly. Always great to see all these individuals. Oh, Dr. Piggott, hello. Glad you're here. Stephanie Kubo, hi.
Hello.
Hi, Janine.
Hey, how are you? Kimona, hello. Stacy.
Hi, Janine.
Okay. Hi there. Okay. So hello, Courtney from Community Health at Northwell. Hi, Tavora. I'm just looking in the chat quickly. Kimona, Dr. Andrea Alt-Brutus, hello there. We were just on a meeting about an hour or two ago together. Selena, Kristen, hello. Carolyn, Stu, Taylor, Clovis, Senior Advisor, Community Health at Northwell, hello. Jennifer Norton, hello there, Jennifer. Ashta from Suffolk County Health Department. Gabriel Pareja from Mount Sinai, good to see you, good to hear you and hopefully see you. And Tish is there, and I think I got you all. Okay. So welcome again. As I said, I hope we don't have to use the full 2 hours, but if we do, then so be it, then that's what we have to do. So here we are today. The goal is to decide on what tools we're going to use for this round of the community health needs assessment process and the timeline when we should be analyzing the data. And again, what kind of tools we're going to use to analyze data, particularly the primary data that we want to collect. So I thought I would do a quick refresh, and I'm sure everyone is quite aware of the regulations on the state and federal level regarding community health needs assessments and the subsequent community service plans that hospitals have to write as their implementation plan, and the community health improvement plans known as the CHIPs that the local county health departments end up writing as a result of the data that is shown in the assessments and the other secondary data sets that we review. So let me just bring up, I'm going to share my screen, and I'm going to bring up a couple of documents. Not every single document that I sent to you will we go through today because we would be here forever. But I'm going to pull up a couple of documents that, let me just get to that. Hold on a second. I have it in another spot. I'm going to pull up the, what do I want to look at? I want to look at, there's so many documents here. Not the special bulletin, health affairs. Okay, how to enable Jackson. Okay. The guidance. I want to look at this guidance document. Let me go back to here. Share the screen. I'm having to hold on a second. I have to pull it up from a different spot. If you just bear with me for a minute, I just got to get there. I thought I could pull it up from the email I sent out, but that didn't really work out that way. So let me go here. And China 2022. Okay. So here is 501(c)(r) guidance. Here. Share. Okay. I don't know why this is. Okay, can everybody see the document I'm sharing? The community health needs assessment for charitable
Yes.
organizations, right?
Yes.
I don't need to go through this, but I did provide it to you as a refresher. You know that this stems from the Affordable Care Act, that there was a requirement in there, the language in there that directed hospitals, not-for-profit hospitals, to conduct a community health needs assessment every 3 years, and to make it part of their filing of their 990 Schedule H. And if they fail to do this, file and conduct this community health needs assessment on that 3-year cycle basis, they jeopardize their charitable 501(c)(3) status, and also could face a fine of like $50,000. I don't know of any hospital that's ever been fined yet or had their charitable status revoked. But nonetheless, I provided this so that you could look at this again. It gives good information about the steps to follow to do the community health needs assessment, how you define your community you serve, how we're going to assess those community health needs. And this is what we're going to talk about today, the tools we're going to use to do that. You need to pull input if you've received any input from previous community health needs assessments. You should take a look at that as additional information. Certainly work with public health officials, which is why we do this jointly with the local county health departments, because they are expertise in public health, and in fact do have epidemiologists on staff who have been very helpful throughout this entire process. And so we'll be tapping their expertise again. And how you document your CHNA when it has to be accepted by your board of directors or your trustees, et cetera, et cetera. I'm not going to go through the entire document here, but it's really good information. It's a good summary of what we have to do. Your report is have to make it widely available on the web and in paper copies, and etc. We have to address significant health needs that we uncover through our research. And if we uncover a significant need, but we feel that we're not going to address it for whatever reason in our implementation strategies, then we have to explain why, but that's never been the case, and etc. And that's it. So that's there for you, for your information and to look at. Now, in addition to that, in addition to the IRS regulations, the federal regulations, there's also state requirements to conduct a community health needs assessment. And that, back in like 2008-ish, I'm going to say, the state really, really, really made a push to have hospitals and counties work together to conduct a community health needs assessment, because it makes sense, because we're all pretty much working toward the same goal. And they have always done that. Hospitals had done community health needs assessments, and local health departments had done assessments separately, but now it was being strongly urged that we would do it together. So I'm going to pull up, I'm going to go to the prevention agenda site. If I get this right here. Okay, can you see I'm at the prevention agenda site right now? Does everyone see that?
Yes, it's up.
Okay. So I'm sure you've all been on the site. You know what it entails. There's lots of data in there. That's where all the indicators are housed. That's where the priorities are listed, the 5 priorities, and the action plans that are connected to those priorities are listed. But I thought, again, just as a refresh as to what we're doing, I would take a look at this with you, and if we had any questions, or if any of us didn't really quite understand anything, this would be a great time to talk about it. So if I look at the overview here, let me just move this out of the way, move myself over here. You again can go through this. This is recent guidance that was updated and sent out in April by the department. And it talks about what the prevention agenda is, how it evolved. It began, as I said, back in 2008. It goes by a 6-year cycles. I think we're in the 3rd 6-year cycle at this point. We're looking at the 2019 to 2024 cycle of the prevention agenda. They, through a very cross-section of individuals throughout the state, come together and discuss what priorities should be listed in the prevention agenda. They've got representatives from institutions, hospital institutions, public health, health departments, community-based organizations, and on and on and on. And they discuss and decide what are the priorities that should be listed, the 5 that should be listed from which hospitals and counties can choose. And they really haven't changed too much over the years. And pretty much are pretty much the same. Some of the title and the way they're described has changed, but they've pretty much remained the same. And there are 5 of them, and our charge as a group collaboratively is to, based upon what the data show us, we are to select 2 of those priorities. Usually it's prevent chronic disease, because that constantly rises to the top, as does mental health issues. We will select 2 priorities. And then as we get further into the actual prevention agenda dashboard and the priority plans, you'll see that there are sample interventions. You'll see that there are measures that correlate to those different priorities. And that's what your plans, your assessments, and your subsequent implementation plans are working toward addressing. As you know, the social determinants of health now are very much in the mix of everything. That really wasn't the case when we started some years ago. I'm saying like 8 years ago, as a joint effort doing these community health needs assessments. But over the years, they've become more and more apparent. And I kind of have to say that the Long Island Health Collaborative, which was an outgrowth of that joint effort that we were asked to oversee back in 2013, that the social determinants of health, we as a group embraced that, I think, before they became popular to embrace. And I don't mean that in a pejorative way, but before they became more mainstream and more recognized, that they really do affect health outcomes, to probably much more than people might have thought in the past. And so the prevention agenda has realized that, and has incorporated those social determinants of health needs into the planning and into what they require now of community health needs assessments and the subsequent implementation plans that will be written, and the strategies that will be adopted in order to meet the priority needs and the health disparity needs. So that's also in there in this document. Cross-cutting principles is that the state is now much more focused on a health in all policy, meaning that every sector, all different departments are involved in ensuring the health of the state, including they, I believe, have brought in the Office of Mental Health and the Office and OASIS much more aggressively into the planning of the most recent 6-year cycle and the priorities that are listed for this 6-year cycle. And so here are the priorities. Again, it's prevent chronic disease. And then on the right side, and this all, you'll see all of this on when you go to the dashboard on the prevention agenda, which we're not going to do today. I mean, I think we'll probably do that in subsequent meetings, but I just want to familiarize yourself with and remind you what these priorities are. So it's priority 1 is prevent chronic disease. And there's 4 focus areas from which to choose more pinpointed efforts. And we'll be choosing a focus area or 2. Another priority is to promote healthy and safe environment. And again, there's, I think, 5 focus areas there, with goals are attached to each focus area. Next is promote healthy women, infants, and children. And then promote well-being and prevent mental and substance use disorders. That's a broader explanation for that priority than had been in previous cycles. And then prevent communicable diseases, which will be kind of interesting when we do initiate the surveys this year, because of having just gone through COVID. If communicable diseases, prevention of those becomes a priority, that will be interesting to see. So we'll see how that goes. So that's just kind of a refresh. The role that the Long Island Health Collaborative and the Nassau Suffolk Hospital Council can play and does play in this process is to distribute the Community Health Assessment Survey, which I've provided everyone with a copy of that, and we will be looking at that shortly as well. To distribute that and to analyze the results and to provide that analysis to everyone, so that we can take a look at it as a group and decide, based upon what the data show, what are the prevailing health needs and health concerns. And then again, as a group, under our direction and our coordination, select the 2 priorities that as a region we would want to address for this next 3-year cycle. So in the meantime, until we get more into the weeds, once we start analyzing the data and talking about what other data sets we want to look at, I recommend that you look around the prevention agenda site. And let me just go back here for a minute. Here it is. Let me move myself out of the way again so I can see. Take a look at the dashboard. Take a look at the chronic disease action plans. The action plans for each priority, right? And you can see it gives you overview. It tells you, for instance, if we decide that chronic disease, yes, rises to the top, and we say, well, in the past, we've all said that healthy eating and physical activity are 2 modifiable activities that can really make a difference in the management of chronic disease or the prevention of chronic disease. So we focused on those 2 in the past. That might very well be what we want to do again, or we might say, no, we're not interested in that anymore. We're going to attack it from perhaps this focus area: chronic disease preventative care and management. And so if that's the case, and I know I said I wasn't going to do this, but I am now, so I'm there, so I might as well open up one of these. We'll say, you know what, we're going to do that, and we're going to increase, let's see, we're going to look at the goal of promoting evidence-based care to prevent and manage chronic disease. We like that. So let's take a look at the objectives. That shows you the objectives that we're working toward. We certainly not going to, you wouldn't choose every one of those objectives. But maybe you choose 1, maybe you choose 2. And that's your objective. And then here's some possible interventions that you could use to meet those objectives. And these are just possible interventions. Many of us have the chronic disease self-management programs that we offer to the community. Some organizations put together their own nutrition or perhaps programs about how to manage diabetes. They might not be the Stanford Chronic Disease Self-Management Education Program, but it's nonetheless a program that follows a certain set of rules as to how to teach people to better manage their diabetes. And so you look at that. So it's kind of like a mix of programs. Certainly the state looks much more favorably upon evidence-based programs, but that's not always feasible. It's not always what's best for the community. You do need to be certified or at least have a certified and trained facilitator of those programs to offer them. And it's not always the easiest thing to do. And there's a bit of a time commitment involved with some of those programs. So anyway, that's just to give you an idea. My suggestion is start looking around this prevention agenda website, start clicking around, seeing what they have. I'm doing exactly what I said I wouldn't do, but I'm going to go to the dashboard just to show you. If we go to the dashboard, right, which gives you all the indicators that they're looking at by priority type. And if we look at prevent chronic disease, we're going to see that these are some of the indicators they look at, and then they tell you where they got their benchmarks from, the year it was benchmarked, whether or not that particular indicator is on track, if it's getting worse, if it's changed. And then we as a group will look back at these indicators, and based upon the programs and interventions we put in place, we are able to say, well, yes, we were part of, let's say, we'll take, for example, number 11, I like, percent of adults who participate in leisure time physical activity. Okay, because we decided we're going to focus on physical activity as one of the ways to better manage chronic disease. And we see it's been significantly improved over time for our state, and particularly for the Long Island region. And there are other screenshots and ways you can look at that really show that. And I'll just go quickly there. I think this is the chart. Get it right. Yeah, you can see here that we're way beyond the state, the New York State, the prevention agenda goal, which is the green line. So we're beyond that in Nassau and Suffolk. So we're doing quite well there. And I like to say, because the collaborative and its collaborative partners have had a focus on physical activity, particularly walking, in the past 6-7 years since we formed the collaborative, we can all say collectively, right? Collective impact equals collective credit. I think we can all collectively take a smidgen of responsibility and credit for seeing those numbers improve over time. And that's the beauty of that's really the goal of what this whole collaborative and collective impact initiative is to work together so that we move the needle, right, on the state's behalf, but also we can take credit, whether we're a community-based organization, whether we're a hospital with some kind of program in place, whether a county health department with some kind of program in place, we can say, you know what, there's been a positive and upward trend, and we can take a small amount of credit for that. So that's kind of just the way it's all tied together, and I wanted you all to see that. So let me get out of this. And again, the prevention agenda page, there's lots of resources here. Certainly take a look, familiarize yourself with this. It will certainly help us as we move forward in our planning discussion. So that's that. So we're going to move on. I'm going to stop. I'm going to get rid of this now. Okay, and what I'd like to talk about, well, first of all, are there any questions? Let me stop speaking and see if anybody has any questions. Just unmute yourself and ask a question. Wow, I could not have possibly explained it that well. Anyway, if you don't want to ask a question verbally, you certainly can place it in the chat. I'm happy to answer that. Any question I can, if I can. So having set the stage, and we know what we have to do, and we know that the community health needs assessment is due, the plan, the end of 2022. We kind of work backwards from that, taking into account that that the plan has to be adopted by the boards of directors at the hospitals, and I believe the county health departments probably have an approval process that they also have to go through. We work backwards from there, and there are some hospitals that are not on a calendar year timeline and might be on a federal fiscal year, or a state fiscal year, or a federal fiscal year, and their timeline might get pushed up more. And I think we have one hospital on Long Island that falls in that category. I believe New York Langone Winthrop falls into that category. So not bad for the rest of us, because it just means we're going to get our work done in a timely fashion and meet everybody's deadlines. So if we work back from that, I think we're perhaps looking at, and correct me if I'm wrong, looking at having come together, having reviewed all of the data and made a determination as a group and selected priorities, I would say probably like by April-ish. And then that enables hospitals, county health departments to then present the chosen priorities to their boards of directors, who are required through the community health needs assessment literature in the 501(c)(r)(3) regulations to adopt it, or to adopt those priorities. So that's what I'm thinking right now as a timeline. Any thoughts on that? Okay. So let's just put that in our back pockets right now, that's kind of where we're headed. And so what we need to do then is conduct the assessment. We need to assess, what does the community need? And here is where the Long Island Health Collaborative, through its Community Health Assessment Survey, has been fulfilling that need on the hospitals and the county's behalf for the past 7-8 years or so, with a survey that was developed via consensus among the group back then, with questions that have pretty much remained the same over the course of all those years, that we then take that analysis or those survey responses and analyze those, and then provide everyone and make it available on our website with the analysis of that information, which is really looking at individual and community perception of health needs and health barriers, along with some demographic information. And so we pull that all together, and that's primary data, and that's looking, that gets down to the zip code level, the neighborhood level, and looks at nitty gritty what the health needs are. So we'll be doing that again. And I'd like to pull up the community, and I sent everyone the community health assessment survey, and I'd like to take a look at that, because I think what we have to do, and we don't have to do it today, but again, I think this meeting is kind of just setting us up for what's down the road. We need to take a look at that and decide, do we need to change any questions? Do we need to eliminate any questions? Should we include something about the pandemic? Brooke and I were discussing that yesterday, and at first I thought maybe we should do that, but then I felt, when I looked at the questions, and I'm going to pull it up in just a minute, the survey, that to ask a pointed question about the pandemic would perhaps be rather leading, and maybe we would not really get a true answer. And I think Dr. Buckman, you could probably weigh in on that from an epidemiologist's point of view when I pull that up, and you might see what I'm saying when what I'm thinking when I pull that up. So let me get to that. Community health, blah, 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 where are we? All right, let me open that. Go back and share my screen. Okay. Okay, so there's, everyone see the community health assessment?
Yes.
Everybody see it? Now, it says Long Island and Eastern Queens, and my vote is to just call it Long Island Community Health Assessment. The reason why it has Eastern Queens in there is because, and I don't know if anyone from Northwell's on, but at the time, Northwell wanted to capture its, and I guess maybe South Nassau would want to do this too, wanted to capture in the Far Rockaway area and the Eastern Queens area. They did have populations they were serving, and so they wanted to capture some of those needs, and that's why it says that. And it can stay that way, but I just point that out, that's why it says that, because we're really talking about Nassau and Suffolk County right now, but that part of that Nassau and Suffolk population does seek care in that Eastern Queens area. But be that as it may, this is the survey with the questions that have remained the same throughout the years. And going back to my thought about adding a question about the pandemic, at first I thought, well, maybe we should do that. But then again, I said that might be a leading question, because if you look, for instance, at the first question, what are the biggest ongoing health concerns in the community where you live, right? So you are speaking on behalf of your community. And there's cancer and diabetes and other chronic disease listed, mental health there, weight issues and whatnot. Then there's vaccine preventable diseases. Now, my sense is that that's going to get checked, because we're in the midst of what we've gone through, and everyone has a heightened awareness about vaccines and whether they believe they're effective or not effective. So I think that not adding something pandemic specific, I think that particular box would cover if the individual feels that vaccine preventable diseases or / infectious diseases is now a very high priority in their area without leading the question or leading the answer. That's my feeling. Anyone want to chime in on that?
Janine?
Yes.
Can you hear us?
Yes.
It's Tavora. How are
I
you?
know.
So
I was hoping you would chime in, because you're the epidemiologist, so you know.
well, there are a couple of things to consider. In some ways I agree, because this is still our standard questionnaire, and to use it year to year allows us to have that comparison, so that's helpful. Selena actually brought that up. So I think that's true. I think that vaccine preventable diseases, will people in the general public know that obviously COVID is part of that? Perhaps we could, in parentheses, do examples, and include COVID as one of a COVID vaccine as an example of a vaccine preventable disease, because maybe that would be somewhat informative. So that's kind of what I'm thinking right now. But, especially for comparison purposes, but I'm interested to what others might say.
Yeah. Yeah, I mean, I agree with you as well, Deborah, that this is the questionnaire we've been using for many years. And so for comparison from year to year, we want it to remain the same. But what you would be doing in that particular box choice is qualifying it just a bit more.
Yeah, and that helps with education as well, so
Yeah.
it might be valuable.
Yeah. And we could say, i.e., COVID, comma, measles, just so that we're not only
Yeah.
focusing on COVID, because that's the thing. The minute people see COVID, it's like kind of like this magnet, and I don't want it to be. I don't want to predetermine their answer almost.
I think that's true. We can include it among other vaccine preventable diseases as examples. Exactly.
Right. What is, Dr. Mermelstein, what are your thoughts on that?
Well, I mean, I agree. I don't know if you can hear me.
I hear you.
Yes.
Okay. I mean, I agree it's a vaccine preventable disease. I'm just trying to think of like what examples you would use. So I'm thinking like flu. Yeah, I'm not sure what else you would want to, like, and then I thought HPV, but then I thought I don't want to make a big deal out of HPV. It's
Yeah.
kind of scary. So I don't know if measles is a good example because most people will not see measles, so they're not going to pick that. You know what I mean? So I don't, there's a lot of different vaccine preventable diseases. So
Okay.
you have a whole page of them. So I don't.
Yeah, I know you could have, right. And that we don't want to have a whole page because we have to keep it to the 2 pages. We could say vaccine preventable / infectious diseases, and then i.e. COVID, measles, flu.
Yeah, or communicable diseases.
Yeah, or communicable diseases. And then we would do the same thing in question 2 where we have that box. Ashla, if I'm pronouncing your name correctly, what do you think from the Suffolk County Department of Health? What do you think?
Hey there. I think I agree with what's been said. I don't want to affect the integrity of the survey too much, and I'm hesitant to put examples because I think that will be leading as well. There is a spot for other where people can write in COVID, and also I guess thinking about what this survey is supposed to do for us. And how it's supposed to inform us, like COVID is in the news, it's being studied widely, it's being assessed in multiple ways. And so I don't think that this survey necessarily has to do that job for us. And I'm more interested in how, because of the pandemic, how other health concerns have impacted the community. And I think there is a lot of long-term things that we're going to be seeing because of COVID, just the impact on other chronic diseases as well. So I would leave the survey as is.
Okay.
So can I just offer something, Janine? Hi, everybody. It's Yvonne Speckles from Stony Brook. So,
Hi, Yvonne.
hey. So from the, I've been working with some folks in the wine dance community. With this survey in particular, we just added maybe 3 or 4 questions to the survey. And so since January of this year, folks in the wine dance community have been given this survey. And out of the 210 people who filled it out so far, now remember, COVID is a thing. This survey has been disseminated since January. But out of the 210 people who filled it out, very few of them selected vaccine preventable diseases as an area of concern for themselves personally, or even for their community. So, for the answer to question 1, only 10% of the people selected that. And for question 2, 16%. So I don't know if it's because there are so many other choices for people. Their top 3 were diabetes, drugs, and mental health. Personally, and then also similarly, for the community. So I'm not sure that it's getting lost, or there are just too many choices. But certainly based upon the 210 people who answered these questions, vaccine preventable diseases was not a priority for them. I don't know.
Well, it
Yeah, this is
could
Greg
be,
Piggott in Suffolk. I think vaccine preventable diseases is public health speak, and it needs to be broken down
yes.
into layman's terms. Are you saying measles? Are you saying
Mhm.
mumps? Are you saying diphtheria? Are you saying pertussis? So I think that it's just too. It's not that we talk about the reading level of people or people's understanding. It's not literate.
I'm getting the sense that that might be the issue. Because vaccine preventable diseases, yeah, I think a lot of people might not even know what that means. And if we say, and I think Tavor, you said communicable, somebody said communicable diseases. I'm not even sure if that's.
Yeah, I agree. I mean, if you look at all the other choices, they're specific. Diabetes, we know what that is.
Right.
Heart disease. This is kind of nebulous as far as what it is.
But it also, understand too that the survey has to be able to align with the prevention agenda priorities that are offered to us. And one of them is about preventable infectious, vaccine preventable infectious diseases. So we have to be mindful of that as well. I think that there's definitely kind of two sides of this because as Ashta had said, if you do put in examples, it may affect the integrity and may again be causing the individuals to check a box because it's very leading what we've put in. I don't know.
Janine,
Yep.
this is Stacy. I was wondering if you were to put vaccine preventable diseases, you could put a definition of what that means. Like a define, I know that we don't want to put examples because it might lead people.
Yeah.
But if we included vaccine preventable diseases, a small definition with some example, but make it more like a definition, like define it.
Diseases you can catch from another person that can be prevented by a vaccine.
Something along,
Something-
something along those lines, but I understand about not wanting to give examples, but I thought maybe,
Yeah.
maybe a few, you don't have to put all the examples, but maybe
Yeah.
a few, would a
Some-
few be
right.
misleading as opposed to all of them?
So more of like a Go
Just
ahead.
one point, that not all infectious diseases have vaccines that can prevent them. And the vaccine preventable component or that priority was one that was listed in the prevention agenda, which is why we chose it, not all infectious diseases. So there is a difference. I think that you're right, the public doesn't necessarily understand what we're talking about. I think it's fine to put a few examples in and not worry about it affecting the integrity of the survey personally. That's my personal opinion, but I'm fine leaving it or putting some examples. I don't think we should spend too much time on that one option.
Another suggestion might be to have split it into two categories and just put vaccines, which I think everybody knows, like if you're concerned about vaccines and getting vaccines for your kid, or maybe there's too many vaccines or whatever your concerns are, and then having another one for infections. That might be another, or diseases, that are infectious diseases or something like that. That might be another way to go about it.
Yeah, I agree. I just don't want people to think that is your concern about vaccines and it gets interpreted politically. Is it concern about their kids getting a vaccine or, mandating a vaccine? You know what I mean?
Yeah,
Yeah.
that's a good point too.
You could put vaccines specify and ask people, right? But you're going to get all of the above, people who complain that my kids take too many vaccines, and people complain that I don't have access to them, and people who complain that they're not effective or they are effective, whatever.
All right. Well, I mean, we don't have to decide on that vaccine preventable diseases choice today. But I brought this up because obviously the pandemic has caused a certain amount of sensitivity for everyone. And I think given what we've gone through, I have a sense that people do know that a vaccine can prevent COVID or can mitigate a very bad case of COVID. I think in the general public, we've pretty much educated all of them about that, and they would know what that means when they see vaccine preventable diseases. But Dr. Piggott, you feel it's still not in literate terms as it needs to be. What's your suggestion to make it better?
I think you need to put some specific vaccine preventable diseases.
Okay. Okay. All right. So let's not, what time is it? It's almost 1. Okay. Let's think about this a little more because we're going to have subsequent and follow-up meetings. Obviously, we know that's for sure until we get this right. Let us think about some of those choices in number 1 and 2. Somebody mentioned about the consequences of COVID that are going to affect people for perhaps many months and years to come. And people might have that on their minds, right? Certainly if they have had COVID and had some issues, or they know of somebody who did, or they're just very sensitive about the whole COVID issue, they may very well, I think, are going to check off mental health, right? Because everyone's so anxious and this has really affected people's mental health. So I think we're going to capture, even if we don't say COVID specifically, we're going to capture those, if I'm explaining myself correctly, we're going to capture those concerns and illnesses and diseases and conditions that COVID will have exacerbated for people. Does that make sense? Like, I think that's inherent in some of the questions that we have here and the answers. And again, COVID might not be a concern we might be surprised and people might feel like,
For your mental health, depression/suicide, you might consider adding a /anxiety.
Okay. Okay. But am I explaining myself correctly? Do you know what I'm saying about when people are reading this? And, of course, it all depends on their own personal circumstance and what's happening in their own communities as to how they will respond. And we can't ignore that COVID is in every community. We know that. So it's in every community, some communities more so than others. And there may be, I do believe that people are going to have that in their mind when they're answering these questions. So, which is why I don't think we have to make something, I don't think we have to add a separate question about the pandemic or COVID or anything like that.
Can I just ask a question? For 2020, did you see any difference in the responses compared to prior years?
I did, and I sent that out to everyone, but I don't know offhand. We did not see mental health rise to the top. That was surprising. I thought for sure that would be up there, but that wasn't. It was again cancer and I can't remember offhand. I sent a release out about it where we had the 2 results analyzed, but there wasn't much change. It was still chronic disease. But as I said, I was surprised to see that mental health didn't pop to the top, was not way up at the top, which I thought it might have been. So I'm not an epidemiologist, I'm not a clinician, but these are just my general thoughts, having been involved with this survey and the analysis of this survey over the past 8 years or so. Those are my thoughts. What does other people think about that? I mean, those are my thoughts as to why I wouldn't want a separate question about the pandemic added. Does that make sense?
I mean, I agree. It's covered. Even like question number 3, what when you look at barriers, if you're
Mhm.
fearful about COVID, there's a fear question. So, I mean, it kind of fits into the other categories of what
Yeah.
you.
Right. I mean, I know when this survey was initially designed and by many of the individuals on this call right now, there were great pains taken to ensure that we were covering all the bases, so to speak, and that we were making it as clear as we possibly could. So I think, I think we're in pretty good shape with it still. But I did want to take this opportunity for everyone to take a look at it in light of what we have just gone through and are going through. Let me move down a little. Health screenings that are needed. Okay.
Since question number 3 was mentioned, can we just talk about question number 3 for a quick second? Question number 3 talks about what prevents people in your community from getting medical treatment. And I saw we've seen that a lot of the answers came back as no insurance, which always strikes us as a little strange since like 95% of the people in New York have some type of health insurance. I was wondering if that question, because it seems more like a perception of people thinking why others aren't getting health insurance, why others aren't getting medical treatment. What if the question got changed is what prevents you from getting medical treatment in your community? Because it could be that they do have health insurance, but they can't pay the deductibles, or they do have health insurance, but they can't find a doctor that fits their network. Or, transportation is an issue. I'm wondering if it would elicit some different responses if we asked people what was preventing them from getting insurance, from getting medical care, rather than what the perception of the people in their community for not getting it.
I think that's an excellent point.
Yeah, that is a good point, and that has baffled us every time we see this, and that's always at the top, no insurance, and we're like, wait a minute, you have 95% insurance coverage, so what's going on here? I've always thought that it's perhaps people have insurance, but they might have high deductible plans and they don't really have great insurance. And so they go to the doctor or for a procedure and they end up having to spend a few $1,000s anyway. And they kind of take that as really more response would be inadequate insurance. But I don't know. I don't know why we asked this question originally in terms of the community and not directly to the person. I really don't.
I just thought,
I think we did that so that people would be more honest, so that, they might be answering for themselves as well as their community. But actually, if I can go back to that wine dance survey that we're currently doing with that question, people are checking, no insurance as a number 1, but the second one is unable to pay co-pays and deductibles. So, there is some relation there, I think.
Yeah, I think the no insurance is correlated that they have insurance that's not the best. That's what I think it is. But that's an interpretation. That's totally
that's why I
subjective.
was thinking if we made it more specific to the person, because the work that we do here at the council, a lot of people will say I have insurance, but I just can't afford it.
Yeah.
So, they admit that they have insurance, but they just can't afford the premiums or the copay or the high deductibles, especially since a lot of this insurance from employers are turning into high deductible health plans. It's really making them unaffordable.
Sake of continuity, maybe it would make sense to add that after the question about what prevents people in your community.
Yeah, there's also people who have insurance, but it's like where they like to go for their healthcare doesn't take their plan.
Right. Maybe no insurance should be inadequate insurance, or maybe we shouldn't have a choice there at all for no insurance, that we should just leave unable to pay co-pays, deductibles, which is an indication that it's inadequate insurance.
Or you could put insurance.
And at the bottom, when you go further down at the bottom, we ask a question if a person has insurance or not, and whether it's Medicaid, private insurance, or whatever the questions we ask. So That might give us a clearer. So if we go away on the bottom,
No, I think the choices are fine, including no insurance. I just thought of changing it from a question that asks them to give a perception of their community and focus it more on themselves. Like it would be more accurate if they were to answer truly for themselves as opposed to a perception.
but I think Yvonne, I don't know who said it, felt that we phrased the question as community because we felt people would be more truthful rather than if we asked it of them personally. I don't know.
Yeah, because later on, we're asking them the type of insurance they have
Right,
anyway.
that's what I'm at the bottom and it says Medicaid, Medicare, private or no insurance. So
Right.
I'm saying, why do we say no insurance as a choice then if we feel that it's not, it's, you know, if it's truly that they have inadequate insurance, which has to be because so many have insurance, then unable to pay co-pays, deductibles would reflect that. And we should maybe take the no insurance choice out.
Yeah, well, I know certainly in that same wine dance survey, 186 people answered that question and 38 of them said they don't have insurance, which is 20%. Still said they had no
Most of
insurance.
them answered that others don't.
You know, given the choices, Medicaid, Medicare, private, commercial, and no insurance, 20% of them still selected no insurance.
At the bottom, at that last
Yeah,
question.
question 23.
Okay. So, well, could be, and I guess, you know, just because 95% of the states covered, there can be pockets where there are higher, you know, that's an overall state number of 95%. It could very well be in Wyandanch that there are 20% who have no insurance.
Yeah.
So, well, no survey's ever perfect, right? And again, this is perception, so it's only going to give us the results based upon how a person is interpreting the question and the answers. So I don't know, you know, and there's always that section for other where somebody could say insurance not adequate. I don't know, or we change it for what prevents you. Could it say what prevents you and people in your community from getting medical treatment?
No,
And
those
then-
are two separate questions.
Separate, okay. Well, I mean, we could add, I guess, another question, what prevents you from getting medical treatment, and then give them the same choices?
I think you and your family, because if it's a parent, then their kids might have, you know.
You and your family?
That other question.
That would have to be another question though, right?
Yes. In my opinion.
Tabora, what do you think?
I think you can add another question. I think that that's okay. I don't know that I would remove the question about the community. I agree. I don't remember the reason why we had community there, but I guess it was from, you know, we had modeled it, or was it part of the prevention agenda or whatever. But you could add a question, see if we see any differences, then we'll learn.
Mm-hmm. All right, so let's consider adding a question, just logistically for us, we have to figure out how to do that without increasing the number of pages, so.
Yeah,
And not
that's part of question.
and not making the type so small that no one can see it. I mean, it's fine on SurveyMonkey because it doesn't matter. And that's the preferred way we wish people would take the survey, but that's not how it happens. All right, so that's for us to figure out. We can probably figure out how to do that, to add that other question. All right, so we're going to add a question there. We're still not certain about 1 and 2, where we say vaccine preventable diseases. Should we give examples, not give examples? The jury's still out on that one. We don't have to decide that right away. What's most needed? I think this is covering a lot of the social determinant of health concerns. And health screenings, same thing. We're very specific in the HIV, AIDS, and sexually transmitted diseases screening. And I don't know why we are that specific there. I guess because
Janine, that was definitely part of the prevention agenda. It was separated from the others.
okay. And then a choice screenings, education, vaccination, and immunization is listed there too. So perhaps there are individuals who felt that they did not have adequate access to the COVID vaccine, then they might check that off. Where do you get your health information? This is always very interesting. Number one has been doctor and health professionals, so that's good. But what's moved up to number two in the most recent analysis was the internet, which is not good. But that's our reality. And then for statistical purposes, we ask these questions. Brooke and I were looking at this yesterday, and we see it says zip code where you live, and then it says town where you live. To me, that's confusing. I think it should just say zip code, but what's everyone else's feeling? It's not always completed. Like sometimes it's just the zip code, particularly the paper ones. It's just zip code is filled out and not the town. And sometimes it's vice versa, and then we have to assign a zip code to that town.
So Janine, the reason we had two, I remember specifically, is because the public was confused and sometimes they didn't know their zip code, so we asked them for their town. We ultimately look at information by zip code, but it was kind of a check.
Okay, that's why we did it. Okay.
So could you just write town/zip code and not have it as a separate?
People messed up their zip code.
Okay.
Okay. Yeah, so there are individuals, I guess, that don't know their zip code, but they know where they live. You know, like they know they live in Hampton Bays, for instance, but they can't remember their zip code. And
Well, I
then,
think-
946.
Yeah, but I think the thing too is there's some people, you know, I mean, I think if you ever wanted to drill a little deeper to particular areas in a zip code, you know, for example, you know, I'm going back to the Wyandanch survey, 11798 could be Wyandanch, but it's also Wheatley Heights. And it's you know, it's the same zip code, but there's two different socioeconomic status issues happening there. So if you ever want to look further, it might be helpful to have that town.
yeah, I think that happens in parts of Hempstead too. Particularly when there's the zip code that includes the college. It kind of skews everything. Anyway, all right.
Just to go back quickly to question 3, there's some discussion in the chat about some other options that we may want to consider adding.
Okay.
So Andrea had suggested immigration status as another option, you know, for a barrier to care.
Okay.
And who had, Shola proposed adding unable to attend appointments during business hours as an option, which I've never thought of that. I think that's a great point.
What does the group think about those additions?
I'd agree.
I'm a little wary on the immigration status. Sometimes asking the question simply will dissuade people from answering the entire survey. I think the schedule is an interesting point too. I mean, I think that's a good idea.
I agree on the immigration status. I think that's a deterrent.
And the only thing I would say, this is Andrea, is that if you add it to the question of community and not to the question about for self, because this is the original question is what prevents people in your community from getting medical treatment? So it's not an indication that, you know, it's your immigration status, it's people in your community.
Okay.
And a lot of people have been fearful to get, I mean, we see in the literature, I mean, this is a common reason, especially in Black and brown communities, for people not getting treatment, for not getting healthcare.
Right. Just to add to that point, this is Shola. I think if as we're saying, we will add another question that is specific to you and your family, adding the immigration status option to the community question will highlight that distinction between the two.
Yes,
So no,
yes,
it's not about you and your family. We're talking about literally the community. So I think that will kind of highlight that. And I do think that's an important option as well.
that's a good point as well. Yeah. Tavura, what are your thoughts on that? Would that solve the concern that the immigration choice would be a deterrent to completing the survey if it's included only under the community part?
I guess I think it's better if it's as part of the community. I still am just in general wary. We work with a lot of undocumented individuals, and even if the question comes up not directed at them or about individuals they know, that, you know, it can dissuade. So I just have those concerns, but, you know, we can add it, we can try it.
Is the correct thing to ask immigration status, or is it residency status or documentation? Because you say you're undocumented, it's different from, I mean, I might be an immigrant, but I'm a legal immigrant, and then that might not
Well,
be.
the immigration status terminology is what's most often used, what I find. I don't often find people use the term residency status, but that's just from the work that I've done. I could, you know, other people could have other experiences with, you know, different terms.
I think immigration status is a more encompassing term to use because that includes different levels of residency that you might have at a particular time. Is that right, Andrea?
Yeah, yeah.
Yeah. Okay. All right, so let's just keep that again also in our back pockets right now. I think what we're probably going to do after this, we're done with this call, is we're going to revise the survey and we're going to add all these changes that were suggested. And we'll have another conversation, right, in our next meeting, because we certainly want to get this going, the survey, and get it out there, but we're going to have another conversation, and that's where we will definitively decide what's in and what's out. But right now, this was just kind of the opener, where we all were in regard to what we have to work with. Let me move back.
I just had a question. Sorry, it's Asta. I just had a question about timing. With this new survey, when do you hope to get it out? Like, when would it, is there a particular date that you're looking for? Is it for just 2022 analysis?
Well, the survey itself is ongoing, right? So it's always being promoted and always being pushed out, and hoping that partners like those on the call right now push it out among their patients and their clients and constituents that they work with and serve. The regulation on the federal level says that a community health needs assessment has to be conducted within the year when the community health needs assessment is adopted, and or from 2 prior years. So we can send this, we can work on data that's sought in 2021 for 2022 community health needs assessment. What we do is we analyze data every 6 months. Last year, we just did it for the full year because of the weird year we're in. But we will be looking at all of 2021. And then we're looking at a deadline of about April of 2022 to make our decision on our priorities. However, we will still be sending out this survey in 2022, but we'll not have an analysis. I mean, we could do a 3-month analysis, but it's certainly not going to be as thoughtful or provide as much insight as one that will have looked at a full year's worth of surveys. So the answer, I guess, to your question is it's ongoing. When we decide that we're going to make any changes to this particular survey, we'll push it out immediately. we'll make note that as of such and such a date, we added changes or we added a question or changed answers to questions, so that analyses moving forward will make note of that, right? So that when we do the comparison from year to year, we know that there was a change at a certain point. So as soon as everyone is happy with this, we're going to start pushing it out.
Okay, thank you.
Okay, let me go, let's see. Let me go back here. And the screenings. Okay, we're back to the demographic questions, right? Right. Now, so Tavora, you answered the question about the zip code where you live and the town where you live, why we did that. I'm glad you remember because I don't. I have a question. We asked race, do you consider yourself? And I think we used to include Hispanic and Latino there, but then we moved it out separately. Can somebody remind me why we did that? Because
It's, so Hispanics or Latinos is considered an ethnicity, not a race in terms of census information. So that's why we separated it. We understand that people don't know how the census collects data, but it helps us in order to organize the information once we get it.
Okay, so we're following what the census does.
Yeah.
Okay. All right, languages you speak, annual household income, level of education, employment status. Then we ask about insurance, and then the type of insurance. And we have the question about the smartphone down there, because I believe historically we found that, particularly in those higher need communities, most everyone had a smartphone, but they might not have a Cablevision account or Fios account or whatever account, or maybe it's different now, right? Because there's all these streaming services. That's why we added that question. Is that still valid to have in there? Because we're thinking about how health messages can be delivered. Is that still worth it, do you think?
My assumption with that question, and it's Shola again, is that we would also have to ask a question about internet. I don't know if maybe I missed a question about internet access, but smartphone is great unless you don't have a data plan or you just don't have access. So if the question is related to being able to receive health messages through a phone, then you would have to know if they have an active data plan that enables them to access the internet through that phone. If the question is more so general, it would also have to be about their internet connectivity in their home or just their access in general. Can they go to a place where they can access the internet, or just at home, can they access the internet? Because it really depends, what kind of device we're talking about.
Okay, so now, so you're bringing up the issue of broadband accessibility.
Right, because if we are trying to gauge a community's access to internet for like telehealth connectivity for certain services, that's a whole nother thing.
Right.
They might not have a smartphone, but they have a laptop with internet connectivity in their home or in a library. But you know what I mean? So it's just, there's so many different ways.
I know, it's a struggle, right? To what questions to include, what not to include. I'm going to say, Tavora, that question was added about 5 years ago. It wasn't in the original survey, if I recall, the very, very first one.
You may be right. I think that was added.
I think we added that, and I think it was because we were finding that through some other research data sets that we looked at, that the communities of higher need, lower socioeconomic status, had the smartphones but didn't have the televisions and the cable. And we found that to be curious, and we wanted to test that and find out, was this more widespread? But maybe now the question isn't a smartphone. Maybe the question now is, do you have broadband access?
Yeah, that could be. I'm curious what the Wine Dance survey is showing right now.
Yeah, what'd that show, Yvonne?
Hold on, let me pull it up. This about telephone.
Yeah.
Or, okay, so do you have a smartphone? 178 people answered. 80% said yes. As far as where you got your information, I think we did ask that.
Mm-hmm.
I'm trying to find it. We did ask. Oh, one question we added, by the way, was because of COVID, does technology prevent you from accessing any of the following: healthcare appointments, other benefits, such as unemployment, remote education of children or self, working from home, or looking for employment? That was when we added because of COVID. But let me go, I'm looking for.
She had 80% said they had a smartphone. And does that mean, did the other ones all say no, or they just?
Yeah, it was a yes, no question, and the other one said no.
So 80 had it, 20 didn't.
And okay, here you go. Where do you and your family get most of your health information? Now, you have to keep in mind Sun River Health was a partner in this. And so people were at the clinic when they filled out the survey. So, you know, but 70% said doctor or health professional. The next by far, so I don't know if Sun River skewed it at all, but the next largest group was 36.76% said internet. So internet was number 2.
Yeah, no, that aligns with the results that we calculated for all 2020.
And then the next highest one was a tie between the health department and the hospital.
Oh, all right. Just want to say one thing about that wine dance survey, in case anybody's wondering, is what we've done in the past. Some institutions, community-based organizations, hospitals, whatnot, have asked to use this survey and wanted to add some questions and modify it for their own use. And we've done that. And it's a separate Survey Monkey link, and the results are kept separate. It's not part of our analysis. I just wanted you to know that it's done for those very specific purposes of which those organizations inquire with us. Now, interesting that you asked the question related to COVID about telehealth and access and all of that. You know, we have to understand that COVID is going to go away. Yay, I'm being very optimistic. And that in 2-3 years from now, when we're continuing to survey the communities and hoping that things are improving, that might not be relevant, a question that's very specific, you know, termed in terms of COVID. So just keep that in mind too. All right. So regarding the smartphone or broadband access, if the internet is coming up as number 2, where everybody is getting their health information after their physician, then having broadband access would be something we should know that people have or don't have, even though we don't want them to go to the internet. Right? Should we change that smartphone to broadband access? Or do you have a smartphone, yes or no? Do you have broadband access, yes or no? Just add another question to the right of that.
I would be hesitant to remove any questions just for, once again, the sake of continuity, but that's just my thought.
Yeah, I mean, we could add it. Do you have a smartphone? Yes, no. Do you have broadband access? Yes, no. We could do that. So I think we'll consider that. Okay. All right, it's 1:20 already. 2:20. What time is it? It's 2:20, 2:25 already. 2:22. Okay, so we will make these changes. We'll circulate this again to everyone. We're going to put some timelines and deadlines and everything for everyone to get their input back. We're probably going to have to actually take a vote, right? Because we want this to be, I don't know if we can get complete consensus, but we'll have to do majority rules depending upon what the responses are to the changes that are made. So let's put this one aside for now. Let me stop staring at the screen. And what I want to pull up next is the community-based organization survey that was used. It says 2014, but it was actually back in 2013 that we used it. It was one of the very first tools we developed. So let me pull that one up next. And that's the community-based survey. Let me go here. Okay, everyone see that? This is a survey, right? So one of the things we have to do is assess the community, right? Individuals and community need, but then also speak to community-based organization leaders who tend to community members. And back in 2013, we developed a survey that the collaborative sent out. Well, we weren't the collaborative back then. We were just a ragtag group of people. We didn't have a name back then. But anyway, we developed this. We put it on SurveyMonkey. We provided our partners like you with the link to your community-based organizations you work with. You sent it out. We got as many answers back as we possibly could. And so this now looks, because the regulations also require that we speak to and get input from organizations that are working with the community members, those organizations that are the boots on the ground, the Island Harvest and the faith-based organizations and YMCAs and American Heart, and on and on and on, the whole bunch of them that we've been working with right now for years, 8 years or so. So there's this survey. We used that back in 2013. So just keep that in your mind. In the previous 2 cycles, the way we connected with the community-based organizations is back in 2016, we held community-based organization summits, one in Nassau County, one in Suffolk County. That was overseen and coordinated by the Long Island Health Collaborative. Though, if you recall those sessions, I think about 100 community-based organizations total between the 2 counties were involved. We recorded those sessions. We had them transcribed and we ran it through the Atlas TI qualitative analysis software to look at key themes that popped up. We did a nice report about it. And we used that to meet that requirement of having heard the voices of those who work in the community. In 2019, we used focus groups for individuals that were held, and we had a firm do that for us. And then they also did key informant interviews that we worked with a firm and they did a report. So that's how we reached communities, CBOs in 2019. Here we are now in 2021. The Long Island Health Collaborative is no longer a state-funded initiative. So we have limited financial resources and limited human resources. It's just Brooke and I. So I doubt that we can do a community-based organization summit. And we certainly can't afford to have any firm come in and do focus groups and community-based focus groups. So my thought was, maybe we go back to using this survey, again, look at it, see if we need to make changes and use the survey. At the bottom of this survey, the person is asked, to give their name, and it says, can we contact you so you can tell us more of your ideas about blah, 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 blah. And those who say yes, assuming it wouldn't be a great percentage, but I don't know, maybe 25 say yes, 20 say yes. I'm thinking we could take those 20 who say yes and develop a subcommittee and divide and conquer and have a list of maybe 5 questions total not even 3, 4, whatever it is, and do key informed interviews via phone or Zoom. And we could record it. We have Atlas TI software here, although Brooke and I are just very much amateurs using it, but that doesn't mean we can't figure it out and learn it. We could do that. And then we'd also have that in addition to the survey results. And then that would take care of reaching out and getting that community-based organization input. So what are the thoughts about that?
Janine Tabora, in the absence of, you're right, having the funds to do a more in-depth analysis of the community-based organizations, I think that's a decent answer. Perhaps, we could, I guess this is a broader question, but if there are funds out there that we could tap into, then that could be used. But in the absence of that, I think it's okay.
So to use this survey, and we will quickly look through the survey, because I'm sure everybody's getting tired, because I know I am. This is a lot of information to absorb in an hour and a half, 2 hours time. We can use this community-based survey, send it out. Preferably it's completed via the SurveyMonkey link. However, there are some people who don't, that's okay. Then we'll manually go in and input the information. But of the number that say yes, you can follow up and talk to me. We could, as I said, develop a very small subset of this group that does that. And if it's a really small number, like 10, then I can just do it, because I'll just get on the phone and I'll talk to 10 people and take notes, and then I will work with the Atlas TI software to come up with an analysis. So does that sound like a plan of attack that would make sense for everyone at this point, given that, like Tavora said, there isn't any funding unless funding suddenly appears and we're able to access it, then we can farm it out? I think that makes sense. And these questions pretty much mirror what we asked on the individual one. There are some changes, and I don't know. I don't know if you want to go through it question by question at this point. If tell me yes, no. Anybody interested in going through it at this point, or you want to just go through it at your leisure and then respond with suggestions by a certain deadline? Uh-oh, somebody left. They can't take it anymore. I think that it, as I said, pretty much mirrors what we have.
Good afternoon. Nice to be covered.
All right, any other questions in the chat, Brooke, at this point about the CBO survey?
Not about the CBO survey.
All right. So the way this would work, right? So we would want to get this out as soon as possible as well. Actually, we could probably send this one out in the beginning of the year, of next year, like early 2022. Probably be a good time to send it out. Hello?
Grace, I don't know if you can hear us. Or Janine, would you mind muting her? I think she's on a call. I don't want us to eavesdrop unintentionally.
No, I don't hear her now. So the way I would approach this is, oh wait, she is. Let me see. Hold on a second. Where is she? Oh, it's quiet now. So the organizations, the county health departments, the hospitals, who work with community-based organizations and CBOs that might be on this call would provide would provide a list of community-based organizations they work with to us, right? Complete with email addresses and contact people. And then we would handle sending this out along with an explanation of what it is to those community-based organizations. And certainly we will also draw from our database here of the Kelowna Health Collaborative members. And we've got a lot of community-based organizations we work with. And we would send that out and ask, give it a deadline when it has to be returned. We prefer that they would do it through the SurveyMonkey link, but if there are individuals that for whatever reason have to do paper-based copy, that's fine as well. That's how we would handle that. And then if we got a dozen back or so that said, yes, you can talk to me further, then we would set in motion a process to take care of that, either being Zoom interviews or phone call interviews, and then document that. And that still all would be ready by say the end of March, and then a meeting would occur probably mid-April, and that's when we would look at everything. And I'd send it out ahead of time, but then we would come together, we would look at all the results of the analyses and all the data we've collected, and we would determine and select the priorities at that time. That's the timeline and the process that I would follow to make sure this gets done. Does anybody have any other suggestions? Okay. What do I have next? So I gave you a bunch of other documents to review. One of them being the 2019 CHNA CSP chip template. And what that is, and I didn't give you all the addenda that go with that. I just gave you the template itself. That is a document that the collaborative and the Nassau Suffolk Hospital Council provides. That is a template that your hospital or the counties can use at your discretion to write the community health needs assessment and the subsequent implementation plan that those needs need to be met. That we provide and you can use. And I write it in such a way where in the margins, I have notation where you can tailor your own information. In the past, in the work plan portion of it, which is an addendum, and I didn't send that out to you, but you all should have it. The collaborative has been able to offer some metrics related to what we do in terms of social media and promotion of nutrition and walking and physical activity and the uptake of chronic disease self-management programs, what we've been able to do in terms of raising awareness about mental health treatment and substance misuse. We will be able to provide those metrics, but any other metrics I no longer can provide because we're not funded to provide any kind of chronic disease self-management education programs throughout the two counties like we had the last time around. We are not using the Are You Ready feed portal, so I don't have those statistics or metrics I can provide any longer. So at this point, it's a lot of social media stats that I can offer in that work plan portion that you would add in it, and then I would correlate, and you've seen it in the past, I correlated to the goals and then the objectives, and does it need a disparity or does it help eliminate a disparity, et cetera, et cetera. I can do that for the two priorities for those, for the social media metrics. You would use that in addition to whatever interventions you have going. You're going to put them in your own work plan, and you'll go through the drop-down menu and select the goals that it meets and the objectives that it meets, et cetera. And I'm always happy to help you figure out and do that. But that's where we are this time around. We're scaled back because of the situation that we are in, although I'm happy to say that the Long Island Health Collaborative has been able to continue and still do some data analysis on your behalf, and still convene meetings and still be able to help partners find one another, partners in the space of public health and community health. And so we're grateful that we're still able to provide you with that service, both to the hospitals, to the counties, and to the many community-based organizations that turn to us. And they continue to turn to us. We're often getting requests for data analyses and information. And so we fulfill the need as best we can. So you have that. So I would write that template again. I guess that's my point. That's what I'm trying to say, is I would write that template again, following the same format, giving you as much information and aligning it to the prescribed template that the state provides to us as possible. I don't know if they're going to change the template from the last time around. I haven't seen it yet. I don't think they will. So you can be assured that we will provide that. And I threw in some other articles about community benefit reporting, a recent article from the Journal of the American Medical Association about community benefit reporting that you can read at your own leisure. I'm trying to think if there's anything else I wanted to tell you. You know that there's a collaborative meeting itself coming up on September 23rd. I'm not sure what the agenda is yet. We may be talking a little bit about community health needs assessments, but certainly not in detail like this. This particular community health needs assessment preparation work group is going to be meeting periodically now from here, I would say, until next March. And I don't know if you want to meet on a monthly basis, a bi-monthly basis. I have a feeling monthly is probably going to do it because everybody's very busy. We will be sending out a transcript of this meeting and summary notes from this meeting and all the changes that we discussed on the individual community survey. And maybe we can set a standing day and time now that we can all meet, maybe in person the next time. I had wanted to be in person, but Delta variant didn't allow that. So we'll see. So what's the group think about that? Do you think monthly will do it? Is everybody there still? Did they leave?
Carolyn said that monthly would work for her in the chat.
Monthly would work. I think monthly would work,
So did
right?
Stephanie.
Yeah,
Monthly works.
I think monthly works. And then when we get to the point where we are sending out that CBO, who's that? Monthly? When we're sending out that CBO survey, and then we see how many CBOs respond and want to be interviewed separately after that, that would be a small subset, like a small work group. And that group would probably, have to meet more frequently, but we're not going to be at that point yet. So let us say, are Wednesday afternoons good, or what is everyone, since this is September 1st, we're going to now meet the beginning of October. What's everyone's calendar look like, say, for?
This woman is so.
Gerald, yeah, you were muted. Okay.
Let's look at October 1 is a Friday. And the first Wednesday in October is the 6th. Anybody have a preference of a day a week? Does Wednesday in the afternoon, like 1 to 3 work? Yes? Because if you don't tell me, that's what it's going to be.
In the chat, Stephanie said Wednesdays are typically busy for her. Some
Okay.
others are saying it works for them. Andrea, Asta, Carolyn.
Stephanie, is it busy morning or afternoon? Like is it doable at all? Stephanie, this is Stephanie Kubo from Northwell, right?
Yes,
Um,
Yvonne mentioned Wednesdays aren't great for her.
no,
Um,
I mean,
Lynn? Go ahead.
I don't think anybody wants to talk about this stuff on a Monday. So
No.
does anybody would want to end their week talking about this, say on a Friday morning? No? Friday morning, I'll say it's October 1.
No for Fridays, but
No
Tuesday
for-
worked for me also, said Carolyn.
Tuesdays.
Tuesdays are good, said
Tues-
Grace.
Tuesdays, yeah, I mean, doesn't matter to us here. It's,
No.
we don't care. Tuesday's fine for us. You want to go with Tuesday afternoons? We should have put a poll question up. Then
Yeah, we should have.
Then we could have gotten an answer.
Yeah, a
Oh,
few
yeah.
people are saying, yep, Tuesday works.
Tuesday, good. Tuesday afternoon, 1 to 3. So everyone can have a nice lunch before they have to be immersed in this tedious work at 1 o'clock. Does that work? Yes?
No one seems to be objecting. So.
Nobody's objecting. So we're going to make these meetings standard the first Tuesday of every month from 1 to 3 p.m. And certainly if we can get done in quicker than 2 hours, and we may very well. I mean, this just first one I knew was going to be tough because there was a lot to go over. And we'll send calendar invites out from here until April for the first Tuesday of every month from 1 to 3, and it'll be on everyone's calendar. Yeah. How's that sound? And when we can have it in person, we'll have it in person. And I will provide snacks. I think we're good. Does anybody else have any other questions? Kimona from near Langone, NYU Langone. Are you still on?
I think Kimona might not have a mic, if I remember correctly.
Okay, how about Jennifer Norton?
Hi, Janine. Yeah, I'm still here.
Okay, Jennifer, is all that I've said, is that meeting the needs of your facility? Because you have that different timeline.
We do. Thank you so much for checking in on that. I'm going to have to check with my supervisor. I think April will be tight. I think the challenge is we have to get like final reports to our board of directors because we're on an academic year calendar, and everything has to be like done and buttoned up before the summer. So mid-April is probably cutting it close, but I can confirm with her and talk more with Kimona as well.
Okay. Well, remember, I will be providing you with a template, so you have that to start with for your community health needs assessment.
Yeah, I think that part is set. I think part of what we're just wanting to get a better understanding of is like when the data will be available and how the priority settings sort of align. But I think, are we? So I guess I'm new to this whole new process. Is NYU, because we're with the new merger, we're also trying to align the Long Island campus with our Manhattan and our Brooklyn campuses.
Mm-hmm.
And so just trying to understand, do we also need to sort of align with the priorities that are set for the Long Island Health Collaborative as a whole? Or if they don't align with the other priorities that we're sort of finding within our target community and our other hospital locations?
Well, the way it works, first of all, it's not the Long Island Health Collaborative's priorities, it's the state prevention agenda priorities. We're just the organization that is helping everyone perform the work that needs to be done to get to the point where we collaboratively select 2 priorities based upon what the data show. So in New York City and your other campuses, they may be working on different priorities. than what Long Island needs to work on. So ideally, it would be all Long Island institutions, including NYU Langone, would be working on the priorities that all the other hospitals in the 2 county health departments are working on, based upon what's selected from the data. Now, we will have a 2021 analysis of the Community Health Assessment Survey available probably February of 2022. The community-based summit survey, and we may change this. I had suggested to send it out in early January, but we can send it out sooner. But let's just say with early January, with a return date of mid-February, that analysis can be in hand by March, mid-March. Now, you'll also be independently looking at other data sets, right? You'll be looking at Burfus, NHANES. You'll be looking at Sparks data. I am not able to provide an analysis of Sparks data like I had in the past because I no longer have the funding to do that. So you'll be looking at Sparks data that your hospital can get access to. Unless, of course, there is an agreement or discussion where hospitals want us to do that and decide to pay separately to have an analysis of that done. That's something else to talk about. So you'll be doing those analyses separately. And so by March, you should have all of that in hand. And I had said we would meet March, I think mid-March or beginning of April. And it's going to be pretty straightforward what priorities should be selected because the data is going to tell us. And then that's that. But you really can't, I mean, if you want, the only other thing you could do is you could look at older data separate from what we're doing. If you need to have the whole process complete by the beginning of the summer, I mean, then you would really be, you wouldn't really be in the same loop as the rest of us then. Does that make sense?
Yeah, I guess the question where we're still a little fuzzy on is whether we in NYU need to select, if we're looking at those earlier data and the other secondary sources and doing our own work within one of a target community, and those needs are slightly different or suggest different priorities than Nassau and Suffolk as a whole, are we sort of bound to doing what Nassau County or Suffolk County are doing as well, or can we select priority areas that are more in line with what the data that are specific to our communities are telling us?
Well, the communities that you're going to be looking at are the same communities that we're going to be looking at. So I doubt that it would show anything different. But if you're asking if there's an absolute requirement that you have to select the same priorities that we select as a group, no. But the state very much encourages that counties and all the hospitals in those counties align and choose and work on the same priorities in tandem. And that's the way they've been doing it now for the past 8 years or so. They've pretty much everywhere throughout the state, as far as I know, all the counties and the hospitals in those counties are working collaboratively and have selected the same priorities. That doesn't mean that you can't, if there's a priority selected and a focus area is selected, but you feel, oh, that particular focus area really doesn't meet our needs and you want to choose a different focus area, you do that then. And you can select more than 2 priorities too. You can work on 3 or 4, but this is just what the state strongly encourages. Does that answer your question?
I think so, yeah, thank you.
Okay. I know it's like there's nothing written in statute, but they're kind of like, you really should do this sort of feel to it. So, and it's worked well. as you hear on the partners on the call in the past, to go this route. So, Tavora, right? I mean, it's worked out pretty well.
In terms of, we kind of decide in a general way what our priorities are. Is that what you're referring to, Janine?
Yeah, like we all look at the data and the results and we sit down as a group and we decide, yep, this is what the data show and these are the two priorities that we're going to focus.
So that's historically how we have done it. There, different members of the collaborative may have different restrictions. For example, Nassau County, even if mental health is a priority, like the health departments, we don't do mental health as a general field.
Right.
So we might have to kind of shape it according to what we can provide or we can address or what our community needs. And so I think it does allow each member of the collaborative or respective organization to ultimately make that decision. But there is obviously some areas that are common to all of us.
Yes. Yes. Helpful, Jennifer?
Yeah, this is great. Thank you so much.
Okay. All right, so we're almost at 3:00. So we know we've got our standing meetings time set up. You're going to get the 2 surveys, CBO and individual, sent out to you with recommendations that we discussed, a recap of this meeting. Is there anything else? That's it. You can call me at any time and ask me questions. I'll do my best to answer the questions. I know I've read these federal regulations on CHNA hundreds of times, and every time I read it, I still learn something new. So happy to answer any questions, certainly from the state level as well. It'll be interesting to see when we get guidance from the state. That's another thing. We haven't gotten updated guidance from the state yet on the 2022, what format or template they want that report to follow. I assume it's going to be the same, but we haven't gotten that yet. All we've gotten is guidance on what has to be filed for this year's update, which needs to be filed in December of 2021, but that's easy. That's just a quick update. All right, so I guess with that, I'm going to sign off. I'm going to thank everyone for spending 2 hours with us and wish everyone a happy rest of your summer. And we'll be in touch, Zoom or in person, well, probably Zoom, on October, whatever that first Tuesday is. I think it's the 5th of October. And we'll see you then. Bye.
Right. Thank you, everyone.
Thank you.
Thank you. This is great, Janine.
Sure. My pleasure.
Hi, Janine.